2 years ago, was a new book published called Care of the Patient with a Fragility Fracture. You can go on to the British Orthopedic Association website and you can download that book. It's a set of standards of care for patients with fragility fractures. By January of next year, every single hospital in the United Kingdom will be required to submit their data on femoral neck fractures to the National Hip Fracture Database, so that we know nationally what is happening with the care of these patients and what goes on. Our problem is at the moment we have so many of them that we fix them and we discharge them. We very rarely follow these patients up. We know that's a problem because the patients are living longer. And so the Simple Fracture Liaison Service has started, and in every hospital there is supposed to be a specialist nurse practitioner or a physiotherapist or a doctor, usually run by nurses, who are the liaison service between primary and secondary care, so that these patients are treated properly. And there is now a tried and tested method of assessing these patients for osteoporosis and starting on the appropriate treatment. So that hopefully, in the next 5 years, we will reduce us hitting that Titanic iceberg and us sinking under the weight of fragility fractures. So what are we going to talk about this morning? We're going to talk about these fractures. We're going to talk about fractures of the femoral neck, which are largely intercapsular, so they're fractures that occur with proximal to the right intertrochanteric line within the capsule of the femur, and therefore those are fractures that are likely to have the blood supply to the femoral head interrupted. We're going to talk about extracapsular fractures, which is everything from the intertrochanteric line to the line at the level of the lesser trochanter. And we're going to talk about subtrochanteric fractures just below the level of the lesser trochanter, but not in the diaphysis. These are a special group of fractures that cause problems. We're going to concentrate on the difference and how to recognise a displaced and an undisplaced fracture when it will be intra or extracapsular, because that has great significance on how we manage those fractures. And we'll talk about subtrochanterics. So let's think about intercapsular fractures. They form largely into two groups. The displaced group, who are the vast majority. 80% of intercapsular fractures are displaced. And I'm going to talk about displacement in a moment. Age massively comes into this, and I'll spend a few moments in a moment talking about the young person with a displaced intercapsular fracture. The vast majority are elderly patients who have osteoporosis. Once we're talking about, I'm going to spend most of our lives going to concentrate on the elderly patient. You need to take into account their mobility and their comorbidities. The Americans have a reasonable system of classifying how mobile you are. Most of us in this room should be independently mobile. Well, so this time, I thought, well, that is a question. If you are also staying down from that, you are independently mobile with an aid. So if you work with a stick, you're independently mobile with an aid. Or you work with 2 sticks or crutches, you're independently mobile with 2 aids. Or with a phone. And then you become housebound. You're independently mobile in your own home, with an aid, without an aid, or you're only mobile with assistance with 1, with assistance with 2, or you're immobile. You have to remember that every single patient who gets one of these fractures will draw one level of mobility at best. So a patient who is just able to mobilize around their house, transfer from bed to chair, walk to the lavatory, perform their own toileting, who gets a displaced intercapsular femoral neck fracture, will become immobile. That is the best they can expect. Their comorbidities come into question. Because if you've got, as we are increasingly seeing, very fit elderly patients who get an intracapsular fracture, they present a challenge. But a very fit elderly patient who is totally independent, goes out and plays 18 holes of golf every day, is a totally different person to the demented patient who needs two carers to help them mobilise. And those patients, as you are hearing me, are managed now differently, and there is good evidence for the way they're managed. For the displaced intracapsular fractures, in the young patients, I'll do it in a minute. In the more elderly patients, some you can treat by reduction in fixation, a few. We'll talk a bit more about that in a moment. Most of them are going to get a proximal femoral replacement of some sort, a heavy arthroplasty. Most of them will probably have that done cemented. And we'll have a talk from Matthew in a minute about why we go one way. The evidence of whether you do cemented or non-cemented, whether you do a modular, or a bipolar. There is good evidence for the way you should go. In the fit, independently mobile, there is increasing evidence that they do much better with a total hip replacement done by someone who does them regularly in an operating theatre and with an operating team who do them regularly. Not by a kidney surgeon who's never had one before in a trauma theatre who don't do total hips. The undisplaced fractures are a bit more of a challenge. Again, age comes into this, and I'll spend a moment talking about that in a little while. But the undisplaced ones probably, in the more elderly, should go to the theatre sooner rather than later, because you want to either reduce and or fix those as quickly as you can. And it again depends on the mobility and the comorbidities of that patient. And Matthew will talk to you about the pros and cons of the various fixation methods, whether you use screws, plates, the configuration of those devices. And I'll spend a few minutes in a minute talking about the pros and cons of static locking rather than something that allows compression. Let's just talk for a few minutes about the young intracapsular fracture, because we consider that a surgical emergency. If you have a young patient who is, let's say, under the age of 16, who is fit and mobile, and has a displaced intracapsular fracture, or even an undisplaced intracapsular fracture, those are the patients who want to take to theatre early, so that that fracture is stabilised, so the risk of avascular necrosis is minimised. The evidence is that you should try to get into theatre in under 6 hours from the injury if you can. The reference writer is Mark Suntowski, and that was published over 15 years ago. We do know that if the fracture is more than 48 hours old, it really doesn't make much difference if you take it to theatre later. There has very little difference in the outcome of that fracture. What we don't know is what happens to the patient between 6 and 48 hours. And the real answer is get them to theatre as quickly as you possibly can. I will be very strongly advocate to you that as good as you may do, and as many hundreds of thousands of things as you may have fixed, most of you will have reduced elderly intracapsular fractures, closed, and looked at these on the image intensifier. If you ever take 2 circles and try and interpose those 2 circles so they are perfectly overlapping, you cannot see that perfectly on 2 views of an image intensifier. You need a 3D reconstruction. And when I went to do my fellowship, I thought I'd done 100,000 of these. I thought I could do it easily. Going online with a displaced intracapsular fracture, did a close reduction, looked perfect on an image intensifier. And I was told by my boss at the time, right, you think it's perfect, now work on it. And I insist all my trainees do a small pieces approach to the front to look at the femoral neck, and you will be amazed at how far off you can be. Those 2 circles can work perfect on an 8 millimeter and do not completely overlap. And this is the fracture you want to be perfect. So small pieces of the bridge to lift the anterior part of the femoral neck so you get it reduced, and then put in your fixation device. Now there is a debate about the fixation device, and if you want the best reference for this, Germany's edition, this is Germany's edition of the Journal of Orthopedic Trauma. The whole journal is on femoral neck fractures, and it's a meta-analysis of all the evidence of everything, and it's a brilliant reference. What they have found is that if you put screws into the femoral neck, the vascular supply to the femoral head is probably better than using a dynamic hip screw. However, the dynamic hip screw is probably biomechanically better. There's my change of choice. The reason to do it is to try and stop this problem of volume and avascular necrosis, which is a real issue. And one of the real issues in it is the line of traction, and we'll talk about that. So what's displaced in the intracapsular fracture? Well, if you look at the main view, that most of you will look at and say, well, there's the fracture line there. It's pretty obvious that that femoral head has fallen post-roller inferior, which is the way 99% of them go. That's displaced, pretty obviously. But often you look at the OP, you won't be sure. Now, different countries fix these in different ways. And the Centre Naples, as you know, have a fantastic database. And up until 5 years ago, in Sweden, every single intracapsular fracture was fixed with closed reduction and internal fixation. No arthroplasties were done. And they found, as we have found, that about 30% of those fail. 30% of them will either get volume or avascular necrosis or both. So they swallow the other way and go to the same as we now do, that almost all of this ways intracapsular fractures in elderly patients we would have an arthroplasty on. However, as a chap called Hans Torfors, if you ever meet Hans, Hans is one of those brilliant Swedish surgeons who knows very critically at proximal femoral fractures. And what Hans did is he went back and looked at those that failed that were having a closed reduction. What Hans found was, if you look at the lateral view will give you the answer. Now most lateral views are just like this one, they're pretty poor. They're pretty penetrated in the osteoporotic bone. But what you do is you draw a line from the centre of the femoral head down through the centre of the femoral head. So you have a line that goes through the axis of rotation of that femoral head. You then draw a second line down the centre of the femoral neck. Forget the shaft, it's down the centre of the femoral neck. We measure the angle between those two lines. And what Hans has found is that if the angle is less than 20 degrees, you are highly unlikely to fail. And those patients you can fix and retain the patient's natural femoral head. And they are unlikely to fail, they have 5% failure rate. But if it's more than 20 degrees, the failure rate goes up to over 40%. So the lateral view will help. So we've talked about the intracapsular fractures. If you're going to reduce them in the young, I would very strongly advocate open reduction. In the more elderly, if you can, it's probably a good idea. This is a fracture where you want to get compression if you can, so that you can get the bone is digitated. And the fracture orientation does matter, because your device needs to cross that fracture perpendicular to the fracture lines, and this is important. The powerless free fracture with a very vertical fracture line, those are the ones that often go to non-union, and occasionally you need a subtrochanteric osteotomy to valorize the neck so that you get a more horizontal fracture line. And Matthew will also spend some time with you talking about, as I just alluded, the pros and cons of whether we do cemented or unsubmitted arthroplasty. In the UK, for years and years, these two implants have dominated the market. They've been around for 70 or 80 years, and they're still the most commonly used implants. The one on the left is an osteoporotic, and it's an uncemented implant. The one on the right is a Thompson's implant, which actually was designed to go uncemented via an anterior approach, which is why it has a banana-shaped stem. The vast majority are now put in cemented. But if you use the toxins heavy arthroplasty, you may have them, they're cheap, you have to remember that it has a cut that is unlike any other for hips. The cut must be down on the pericarp. And this one was in too long. This patient will complain of a level discrepancy, they will feel tight, and they are at risk of dislocation. We'll talk about the pros of using cement as opposed to not using cement. If you want the answer for all of that, if you ever want to quote someone with neck and femur fractures, you quote this man, Martin Parker. Martin has done more femur neck fractures than anyone else in the world. He's published more than anyone else in the world. He's so far written 4 popular databases. If you want an answer, go over with Martin. Matthew will summarize that for you. For the extracapsular fractures, there's a problem from Jim about how to work out whether these are stable or not stable, and the pros and cons of using intra versus extra-medullary fixation. And I'm going to spend a little time on just talking about static and dynamic problems. It is a very classical intertrochanteric fracture. Some of us might think that this is an unstable fracture because the eccentric canter is off, so the medial pericarp is gone. It was decided in this patient to use an intramedullary device. We're going to talk in a few minutes about very important. So a new intramedullary device was put in. And here it is, immediately post-operatively, you can see it clips in the skin, and that looks fantastic. We've got a good reduction. We don't worry about the eccentric canter, but we get a good reduction. One little tip for you, if you see a patient who is more at risk, that is an indication that that patient will take twice as long to mobilize as someone whose eccentric canter is intact, because their ISS has been dysfunctioned. So if you see that, do not expect the patient to get up and walk straight away. They will get it wrong. So that's put in, and we get the patient up to walk. And in the UK, we have given up telling patients to touch or partial repair. They can't do it. You need fixation that allows them to fully repair from day one. So we get one, we get the walk. And here is the same patient 4 weeks down the line. Now this implant is designed to do this. It's designed to allow the femoral neck to compress. And it's compressed, you can see, as far as the implant. And that is a very common issue. And we're beginning to recognize that this is probably a bad issue. Because in the young, fit, mobile, or the more fit and agile elderly patient, when this happens, you effectively shorten the femoral neck. You effectively lengthen the abductors. They develop a trembolomar bit. They move around, squeezing the hip because they've got a short abductors. And this starts to run on the arterial band in the thin patient, and there is a problem. And the only way we can actually allow this problem, perhaps, is to have some form of static device. Something that does not allow the femoral neck to collapse. And this identifies that locks the screw into the neck, so the femoral neck does not collapse. Watch this space, it's an unanswered question. The reason it's unanswered is that we've been thinking that collapse is important to get union, but actually non-unions of the femoral intertrochanteric area are rare. As I just said to you, neck length may be more important. So can we do it statically? No, and the suicide of pathology is talking about pathological fractures, because the others aren't going to cover this. And this is a con. You need to think about the cause if you know, because if you know it's a renal cell, then you need to be prepared. Renal cells may bleed. 10% of breast cancer metastases are sclerotic, not lytic, and they're bleeding. And I'll show you an example of that. You need to be aware of that. You need to know about the age and prognosis of the patient, because a lot of them do not know what to do. You're doing this purely for analgesia, to give them quality of life the last few remaining days, weeks, months of their life. You need one films. If you see a femoral neck fracture that has a pathological lesion, you must image the whole of the femur. You'll see why I'm doing. The bone scans will help you to look for other lesions that may be addressing at the center of the mission. not necessarily the same with surgery. You need to instrument the whole of the femur. If you have a pathological fracture of the proximal femur, you must instrument the whole of the femur. That patient does not want to come back for another operation with another fracture in the last few remaining years of their life. I'll talk to you a little bit about this thing called venting, which is important. And you need to do something that allows that patient to fully work better immediately. They won't get a positive life back. Now, here's an example. 58-year-old lady, she's a medical secretary, she's known to have breast cancer. She's referred to from the oncologist, she has no pain. She's referred to from the oncologist, she refuses to stop working. This is her x-ray. If you look carefully, look at that femoral neck, you can see there are lesions inside that femoral neck. And in fact, there are lesions in the other femoral neck. If you're not sure whether or not these need fixing, the reference is by a man called Morel. And Morel has introduced the scoring system for these. You don't really need to know the scoring system. All you need to know for the proximal femur is if you can see the pathological lesion on the x-ray, you've lost more than 50% of the bone. In the bottom of the femur, there is an area likely to fracture. And if they've got pain, you must fix it. Here's their bone scan. Now you can see that she is, unfortunately, riddled. She is full of metastases. For this, you need to instrument the whole femur. So a long instrument device fixed at both ends and fixed statically, because this patient may not heal. So you need something strong, long, and fixed. Now, if you look carefully, down at this end, you can see a little hole and a little hole there. And this femur has been vented. Where the bone is not broken, you have a large tubular in the femur. The moment you put with a sharp wheel or an introduction wire into the top of the femur instrumented, you will throw massive showers of MRI into the circulation. You can reduce the risk of the incidence of that by venting the femur distally before the instrument at the top. So I just take my little drill hole here, and I've got a little drill up there, and I vent it to allow the pressure out. Some people even put a suction catheter into that. But it is an important thing to do in the unfractured femur to reduce the risk of pathological MRI and the patient dying on the table. She had lesions in her femur, and she decided that she wanted to go on fixed, but she got trusted with me and decided to wait for me to come back from holiday, which was a mistake. And I tried to tell her not to do that. She needed to get on fixed soon. And what happened? She got a pathological fracture. So that also gets fixed, but because of fracture, venting is not so important. Now this is fixed statically, right? That nerve will not move. And it is important to do that so that the length is kept, the patient's allowed to get out and mobilize, they can go away from their radiotherapy, so it heals. And you can see all the lesions that develop. And she had another 9 months of quality of life with these before she died from her disease. What about the intercapsular fractures with pathological lesions? These present a challenge, and they do need heavy arthroplasties or some form of proximal femoral replacement. And you are potentially going to be spending an awful money on a young patient who is going to die. Here's an example: 46-year-old lady has 4 children, all the way to 12. She's got disseminated breast cancer. And if you look at this one, this is a breast cancer, but look at the lesions, they're sclerotic. That's a brain bone. You need to image the rest of the femur. Well, here's the lower end of her femur. If you look very carefully, she's got a fracture right down at the bottom. They've got a problem now, because you need to stabilize this whole femur to allow her to get up and walk. In my hands, the only way to do that was to do some form of proximal femoral replacement. This is a thing called a cannula there, which has a heavy arthroplasty at the top, and then I insert a dynamic modular screw into the mount, so the whole thing is stabilised. But, if you look carefully, with the fracture, interrupts the fracture. However, she can get up and walk on that straight away. Manages to get home to her 4 children, gets another 7 weeks quality time with their family before that. And just this finishes the last slide. Just please don't forget the patient. We all look at x-rays, but everything on top of the bones is a patient. And this lady has got a femoral neck fracture. She's got severe chronic obstructive pulmonary disease, she's got severe osteoporosis. She does not want an operation. And there are times when not operating these patients is entirely appropriate. And we need to think about that. You will hopefully, from what we've been saying this course, go away thinking about what we call the 9 P's. Prior preparation and planning, probity, punctuality and politeness prevent poor performance. Thank you.
Thank you very much, for the 3 systematic approach to that.
Okay, we're talking about the extracapsular fractures now. Not related to anatomical trauma surgery, because we've heard from managers this is going to become a very big part of our working lives. It's really going to represent a huge problem in the future. I got my fingers about a month later than Michael, so the number of families gone up to 40,000 already, so it's certainly a big problem. Sadly, approximately 10% dead at 1 month, and 30% dead in a year. Rather depressing. Because the principle is one known age distribution, the vast majority are elderly. We mustn't forget the young and high energy patients. The problem with the elderly patients is they have extremely osteoporotic brain. This I like to think is my bone. This is how I'll be when I'm 80 or 97. The elderly suffer from low knee fractures and they have frequently multiple medical problems. The other article fractures are very, very different, and it means they don't have multiple medical capabilities, but they have associated life-threatening injuries, and it's rarely the hip fracture that's life-threatening. So the aim of the talk is to go over the classification, looking at particularly how the stability varies with these fractures. Talk about bound mechanics and implant options for extracapsular fractures, and then just a few tips in managing these patients. So these are the fractures we're talking about. The 31A, extending between the region of the greater and the lesser trochanter. We look more closely at that group. We start with the stable 2-part fractures, becoming increasingly unstable. And then when we lose the medial buttress or medial calcar, the instability increases. And then we have this sort of specialist group again, which is the reversal medial fractures, which you often see in the elderly. And in this sort of fracture, which in my experience is seen in the young and high-energy patients, it can be very difficult to reduce. So you've got progression from stable, progressively more unstable. Now, the problem with extracapsular fractures is that the femoral head blood supply is preserved. So we retain the femoral head and fix the fracture. So these patients are usually elderly. Either treatment will allow them to fully wake their head immediately. There's nothing between fully wake their head and basically staying in bed or sitting in a chair. So ideally has to be for fully wake their head. You can't tell an old lady to touch weight there or sort of half awake for it just won't happen. The operation should give good pain relief. Ideally one operation, which is straightforward with minimal complications. In our practice, in the UK, the majority of stable fractures and many unstable fractures are treated with a dynamic hip screw. The reduction is usually closed, and the patient's allowed to fully work their body. As we've learned, this device allows compression of fracture fragments, which is good in one way, but in another way, it does cause collapse of the fracture, shortening of the neck, reduction of the abductor tension, and often irritation of the iliotibial band, particularly in the thin patients. Here we see, as we talk about the face, this is a laterally optimal lag screw fixation. Position, the lag screw is high and not central. We'll talk about that a bit later. This is a particular group of fractures that's very important to pick up prior to going to theatre. So we'll look at that very carefully. These can be missed. If we use the normal download screen part, there's absolutely nothing to prevent it. It doesn't really add very little to the spurs of the fracture because it wants to displace in the same plane as the downward motor plane. So, as far as extramodal options for treating reversible limb fracture, we essentially need to buttress that proximal fragment. So we can use a fixed angle device such as a DCS or a blade plate. Increasingly in the reversible limb fractures and in the unstable fractures, we turn to intramedullary alternatives. Here are two examples. Here, these can either be long or short. Think about the bone mechanics of these two options. We have the blade, a long unibarm. In the absence of any moving the buttress, you get a huge bending force on this relatively thin plate. If you look up on the nail side, you've got a raw roller, and it's in the centre of the bone, so the actual bending force there are significantly less. So there are definite theoretical, and there are definite biomechanical advantages where all that is borne out clinically or just in theory, remains to be seen. How far the we know to conserve the blood supply and improve the biomechanics? As we've just heard, the jury is out on whether we should be, whether these nails should be static or dynamic. On some of the nails you have an option of static or dynamic, and some you have no choice. But these unfortunately have a bit of a learning curve. And what you rapidly find out is that actually it's easy to put it in well and in the correct position if the fracture is undisplaced or reduced. But as soon as the fracture is displaced and you haven't managed to reduce it, finding the entry point becomes more difficult, and obtaining a good position of the implant within the head, the lag screw in the head, becomes very difficult. So the fact that we're preserving blood supply only really applies if you're not having to do a big open reduction. There is a tendency to think you can put the nail into the top of the bone in the LV patients, leave it around a bit, and you'll be able to reduce the fracture. It doesn't happen like that. You cut out through the head and end up with the trochanter and wallets that you started with. The early nail, particularly the early down nail, was prone to distal fractures, but now all designs have changed, and distal fracture is less of a problem, assuming you've got the correct entry point. Now this is quite interesting. This shows how nails to rolled. This is the use of plates in red and nails in blue for intraoperative fractures in the United States. So, look, 1999, basically, nearly all of them were plates in 1999, down to approximately 30% in 2006. And the new shiny nails, they're long-lasting, are rapidly increasing their usage. With really very little evidence for the use of the nails, apart from in the reverse limb fractures. Just a little technical tip this time. It's so important with the nail to have a good reduction before you start trying to insert the nail. It's much easier to find the entry point. If you can't do it closed, then I often use a shunt pin, which is screwed temporarily into the proximal fragment, allow you to move around and get a good reduction. Then you can find the entry point and insert the diagram. But reduction and entry points are key to a good name. Now we've heard that there are a number of implants. We've got the extramedullary and intramedullary. The important thing is that whichever implant you choose, that you do it well. Doing well involves planning. Planning includes checking that the equipment is available in the theatre and its style, and also a decision on what we're going to do and why, and what we're hoping to achieve. Here we see a less than satisfactory example. The lag screw is high in the head. The reduction doesn't look fantastic. In fact, we wonder whether the leg cranks out a huge amount of traction. The reduction needs to be careful, preserving the blood supply. If you look at the lateral of this patient, the lag screw is again short, posterior place, and the reduction is full. And really, you know what's going to happen then. Your first chance to get this right, the best chance to get this right, is your first chance. I believe these patients do very badly with the second operation or vision operation. You have to get it right the first time. And if that means calling for help, so be it. The patient is more important than the product. Here's another less than good example. Again, lag screw very high in the head. These are the kind of things we see. Screws cut out, and the load in the acetabulum, this patient with a lot of pain. Here, fracture, and again, the screw close doesn't end. So salvage of these patients isn't actually that easy. I've often presented the quite case after months in a nursing home with significant pain. The options are removal if it's united, but it can be quite difficult to tell where CT scan, etc., where it has united. We can temporary fixation, which is not easy. We can replace with a hemorrhagic cast or total, which again is not without its difficulty. As far as these fixations are concerned, most of the companies producing extra large lag screw, sometimes called the jumbo screw, which hopefully allows you to get a better fix into the bed. The problem is that the head's often fairly empty if you have a lag screw rolling around it. If the screw's been put in particularly badly, it's actually easier to refix because you can, there's a better area of the head left. Sometimes you can refix valves with the environment mechanics instructor, putting a valve osteotomy and a higher degree DHS to give some compression. I'm going to use 6 angle devices. You heard from Graham yesterday, whenever there's an unusual failure, you've got to think about infection before going in again. Hemiarthroplasty, or total at present, is again not easy. Often the trochanter has escaped, it's very difficult to refix. And because these fractures are collapsed, they're often massively expanded, particularly medially. And so you do your joint replacement, but then you get so much impingement from the expanded proximal femur that you have to do an extensive reshaping of the proximal femur to prevent dislocation. So you never get it right the first time. So how should we avoid failure? How should we get it right the first time? Well, we know that the more stable fracture, the less risk of failure. One way of making the construct more stable is with a good reduction. But also, we want to preserve the blood supply. So good reduction and preservation of blood supply must come hand in hand. Whereas in fact, they're often they come from different ends. Probably key is the position of the lag screw. Van Dam came up with this tip apex distance. femoral neck. You measure from where that transects the femoral head to the tip of the leg screw on the other. And do the same on the lateral view. And the tip apex distance is these two distances added together. We know that a good reduction allows easier screw replacement, and that applies to both narrow and diamond thick screws. We know the head on both views is the gold standard, and that's where the best failure happens to be. In Vanguard series, the average tip apex distance for success was 24 millimetres. And they found that if it was less than 25 millimetres, none of their series failed. Just a few tips on perioperative care now. Before you drain the patient, you want to check that you can get a good orthopedic lateral view. You've got to think about the contralateral leg. Often these patients have very stiff legs, stiff hips, or a hip present. You don't do any harm to the other side. They're often very thin and prone to skin bed sores, need good padding. And I see time and time again, people can't reduce it, and you go in there and the leg is like a guitar string, you can almost plop it at the same time. So the first thing to do if you can't reduce it is to take the traction right off and start again. Keep these patients warm, they're prone to hypothermia, they've often been lying on the floor for some time before warm back. It's obviously a bigger problem in the UK than it is in Cairo. We're there fragile skin. And probably my main thing is to call for help early. If you call for help when it's already got in, it's a guy there, there's no big problem. If you call for help when when the head's really out and the latch has already been inserted on it, it's too late to really help. As with all surgery, quality control is important. I believe after every operation you should think, what can I do better next time? Or how can I make my life easier? And you can look at your x-ray efficiency. So to begin with, these are very important fractures. Because they're suffering label, and also because they're embryos. The rare reversible fractures, try and pick these up early. But one choice of implants are rare. But apart from the reversible fractures, there's no hard evidence as to which implant is best. The important thing is whatever implant you use is that you plan to inform the procedure correctly. Thank you.